continuation of these quiz cases, and we stopped here, where you can see cervical CT, and also
degenerative arthritis.
Sorry,
Degenerative arthritis.
degenerative spondylodiscitis, you mean?
Arthritis.
Or spondylodegenerative changes in the cervical spine. This is an 85 years old male, and you can see spondylolysis of C3 over C4, retrolysis of C5 or 6 over C7, and degenerative narrowing of the disc spaces. But what is important is the lesion at the odontoid. And here you see that there is changes in the bone marrow of the odontoid associated with an extra osseous soft tissue component. And if you look to the axial image, you can see erosive changes in the odontoid.
Cordoma.
Sorry?
Sorry.
Oh, yes, answer.
Cordoma.
Chordoma. Any other possibilities?
Rheumatoid arthritis.
Rheumatoid is a very good possibility. Other possibilities?
It can be metastasis.
Can be metastasis, lymphoma, for example. These are all possibilities. But if you look carefully here, and this is a case of chondrocalcinosis, or calcium pyrophosphate dihydrate disease, which affects predominantly the odontoid process, and it causes some erosion of the odontoid as well as the related arches of the first cervical vertebra, associated with the formation of soft tissue mass at that level. Then what is the chondrocalcinosis? And it's also known as calcium dihydrate pyrophosphate deposition disease. This disease can be caused by many of the pathologies like pseudogout, hyperpara, osteoarthritis, ochronosis, gout, hemochromatosis, Wilson, acromegaly, and hypophosphatasia. The main finding of this disease is calcification of the cartilage, whether the articular cartilage or the cartilage of the meniscus, cartilage of the triangular fibrocartilage, for example. And in the odontoid, it is characterized by the formation of a pseudotumor around a pointed odontoid. If you look carefully, you can see that the odontoid shows normal signal, but you see a big mass which is related to the back of odontoid, which is black in the T1 and T2 weighted images. And here are the radiographic and the CT appearance of this disease. And you got calcific deposits in the annulus fibrosus, in the transverse ligament of the dens, and the supraspinous and intraspinous ligaments, in the intervertebral disc, in the longitudinal ligaments, in the capsular calcification of the apophyseal joints. And this is our case, which is a pseudotumor periodontoid mass, and it is also referred in the literature as crowned odontoid. Then arthropathy may also be seen in the knee and other joints in the form of, in the spine, you got narrowing of the intervertebral discs, bone sclerosis, osteophytes, and some joint effusion of the apophyseal joints. Then what do you think of this?
It's a surgical MRI, T2-weighted image, showing at the level of lumbar 4, lumbar 5. There is loss of bite signal intensity, disc generation, and there is disc herniation. I think disc herniation on the right side. In the axial MRI, there's right post-lateral disc herniation.
Granulation tissue also.
And you see that the disc is
Caudal.
going down.
Granulation.
And this
yes,
is
caudal migration, yes.
caudal migration.
Caudal migration.
Then
Caudal migration.
there is a new described sign in the literature which indicates the presence of a line between the disk itself and the other disk component, and this is highly suggestive of disk sequestration. And it's not needed that you see that the sequestrated fragment is totally separable from the disk itself. This sign is known as the double fragment sign. And between the two fragments, you got a line. And if you see this low signal line between the disk fragments, then you can say safely that you are dealing with a sequestrated disk, in spite of the sequestrated fragment is not totally separable from the disk itself. And this is also an appearance of a double fragment sign. And you got herniation and you got some separation of the disc fragment. Then what do you think of this?
Ossification, postural
Ossification of
Yes, and this is ossification of the posterior longitudinal ligament and also some ossification of the anterior longitudinal ligament. But what's important is the posterior one because of the encroachment on the spinal canal and the decompression of the cord. And according to the literature, there are many types of ossification of the posterior longitudinal ligament, like the continuous type or the segmental type or the mixed type and other many types that can be described in the literature. What is important for me is this type that I have seen, that I have seen only in a case, only case in my life. And this, if you look carefully, you see a big calcified mass in the spinal canal. Actually, if I feel that this is an extradural lesion, I will say that this is calcified disc. If I see that this is an intradural lesion, I will say this is a calcified meningioma. But you should remember that this appearance is one of the types of ossification of the posterior longitudinal ligament. And this is another appearance of segmental type of ossification of the posterior longitudinal ligament. Then what do you think of this?
Calcification, intra-articular.
Yes.
Disc replacement.
Disc space cage.
No. This is just calcification within the disc.
Calcification
There
inside
is
disc.
no surgery, and this is just calcium within the disc itself. Actually, you know that I have mentioned that the disc degeneration passes into 3 stages. Actually, there are 4. The first one is loss of water. The second one is loss of height. The third one is the development of intradiscal air, which is known as vacuum phenomena. And the last one is the development of intradiscal calcification. And because of its rarity, I excluded from the types of disc degeneration. But recently, it is presented in the literature, and they spotted a lot of causes that may lead to calcification of the intervertebral disc. And the first is the degenerative spondylo degenerative changes, idiopathic, post-operative, post-traumatic, amyloidosis, poliomyelitis, acromegaly, hypervitaminosis, hyperbara, juvenile idiopathic arthritis, ochronosis, pseudogout, hemochromatosis, we have mentioned, ankylosing spondylitis, and this is known as transient intradiscal calcification in children. Transient means that you got calcium in the disc that can be resolved after that. And what do you think of this?
Fibrosis.
Perineal scarring or what?
Yes, perineal scarring. This is
Perineal
post-operative
scarring.
L5 or laminar fenestration, and you got a lesion in the T1. After injection of contrast, you got enhancement, and the nerve root is inside, and this is perineural post-operative scarring. Then what do you think?
Unstable fracture.
Yes.
Compressed fracture.
Yes, and this is the unstable fracture involving the L2 vertebral body with internal fixation by screws. What's important here is the bone marrow edema of the fracture. Then in cases of acute fractures, you got bone marrow edema of the fractured vertebra. And this edema will appear of low signal in the T1 and the high signal of the T2. And if you inject the contrast material, it will enhance. Then enhancement of the bone marrow edema does not mean that this is a malignant process, because some of the clinicians and radiologists may thought that because of enhancement, you consider malignancy and you send the patient for biopsy. No, this is a fracture. And if you biopsy the fracture, you will add more burden to the vertebra itself. And I emphasize this fact many times in the lectures, that bone marrow edema of whatever etiology will enhance with contrast. Degenerative bone marrow edema, traumatic bone marrow edema, neoplastic bone marrow edema, inflammatory bone marrow edema, all these bone types can enhance with contrast. And what do you think of this?
Cervical MRI, T1 and T2.
Yeah.
Straightening.
Yes.
And multiple decrease the bone height in the.
No, this is myelomylation.
Myelomylation.
Okay.
Abnormal bright signal antitubated image.
Do you feel that this spinal canal is normal?
No, there is
so this herniation between the.
Yes, but
there is edema of the.
That the CSF space along the anterior and posterior aspects of the cord is obliterated, and this is the spinal canal stenosis with multiple disc lesions as well as cord myelomalacia. These are the axial images where you got flattening of the spinal cord, and this is a disc bulge, and this is a protrusion, and this is a disc protrusion. Then you got the spinal canal stenosis and cord edema or cord compression. Then what do you think of this?
Compressed fracture.
No.
Burst fracture of burst.
No, this is not a fracture because the disc is involved.
Infection involved discitis.
Yes. And if the disc is involved, then you think of infection. Old rule. And then the most common type of infection is TB. And then you got calcification, and you got soft tissue component in the epidural space, and also, and you can see this in the axial images, you got paraspinal soft tissue component with calcification around the spine and calcification inside the spinal canal, and this is Bott's disease. Then what do you think of this?
Deceptive vertebra of C of
lesion in odontoid.
Yes, we have a lesion in the odontoid process. This lesion is osteolytic, and there is some erosions of the cortex and the extraosseous soft tissue component as seen in the axial image. Then what are the differential diagnoses of odontoid lesion? There are a lot of lesions that can occur in this particular site. And we have mentioned one of them, which is chondrocalcinosis. And also you have mentioned rheumatoid arthritis, also systemic lupus erythematosus, gout, and this chondrocalcinosis or calcium pyrophosphate arthropathy, gout, then osteoarthritis, infective arthropathy like TB and bacteria, primary bone tumor like myeloma, for example, metastasis, lymphoma, and hyperparathyroidism, brown tumor, and Down syndrome, and Paget disease. Then in this particular case, you see there is a mass surrounding the odontoid, which is an indication of this disease we just have mentioned. But in our case, this is the MRI of the same patient. And you got a lesion involving the odontoid as well as the disc. And this is very important. Involvement of the disc means that you are dealing with an infection. And in the contrast enhanced image, you see what looks like an abscess. And there is marginal enhancement and the internal areas of low signal. And this was proved to be tuberculous changes at the odontoid. Then
Metastasis. This is metastasis.
why metastasis? Do you see a history of primary malignancy?
No, there is a system.
Yes, there is an intradural lesion, okay? And this lesion is of some bright signal in the T2 and marginal enhancement. Then you remember the differential diagnosis of intradural lesion. These are neoplastic, meningioma, and neurofibroma, schwannoma, and metastasis if there is a known history of malignancy. Then the non-neoplastic lesions, intradural lipoma, this is not. Intradural dermoid, it does not contain fat. Epidermoid cyst, maybe. Spinal arachnoid cyst do not enhance. Either neuroenteric cyst will have vertebral anomalies and intradural disc, and this is not an intradural disc. Then if you go back to the lesion, and you see that this lesion can fit for neurofibroma and a schwannoma, for example. One of the important issues to be taken into consideration. If you see a lesion, a cystic lesion, inside the dura, and this may be one of three, as I have mentioned. It's either an epidermoid cyst, or arachnoid cyst, or a cystic schwannoma. If you have the diffusion weighted image and you see diffusion restriction, then the diagnosis will be epidermoid cyst. I hope you remember this fact, which is very important nowadays because of the frequency of the epidermoid cyst inside the dura. Then what do you think of this?
Osteoblastoma.
Okay, this is the same patient with 12 years old with an expanding lesion affecting
the fluid levels.
yes,
Fluid level,
the differential diagnosis. Aneurysmal bone cyst, chondroblastoma, fibrous dysplasia, giant cell tumor, osteosarcoma.
Aneurysmal bone cyst. Aneurysmal bone cyst.
Yes, aneurysmal bone cyst is the diagnosis because if you look carefully and you can see some fluid levels inside the lesion which are almost diagnostic of aneurysmal bone cyst. Then what do you think of this?
Abscess.
Abscess in the colon.
Sorry.
It's a difficult diagnosis actually. Yes, let us analyze the images, and we have in the T2 image lesion that looks cystic inside the substance of the cord because the CSF is obliterated and the cord is expanded. Then this is an intramedullary lesion. Let us look at the differential diagnosis. These are the intramedullary cystic lesions. Number one, Chiari malformation, then the Walker, diastematomyelia, congenital hydromyelia, inserted skeletal dysplasia, and ependymal cyst. Ependymal cyst is like the simple cyst anywhere in the body. If it occurs in the brain, it is known as neuroglial cyst. If it occurs in the spinal cord, it is known as ependymal cyst. Then post-traumatic, you may got injury of the spinal cord and cavitation. Tumors like astrocytoma, ependymoma, and hemangioblastoma. Infections like arachnoiditis, meningitis, and subarachnoid hemorrhage. Then, if you see a cystic lesion inside the spinal cord, then you need the diffusion weighted image. I hope you remember this. You need the diffusion weighted image in order to diagnose epidermoid cyst. And this is one of the supportive findings for epidermoid is to see that the cyst has a restricted diffusion. Otherwise, then you include the differential diagnosis according to the rest of the imaging findings.
دكتور بعد اذنك بالنسبه للصوره بتاعت الابيدرمويد انا مش حاسه ان هي سيستيك هي نفس تقريبا في التي 1
and this is because of
مش قادره اقول هي سيستيك
yes because of the presence of some artifacts in the image, and this lesion is not in the central part of the coil. Then you may got some artifacts that may lead you to think that this is relatively solid rather than cystic. And this lesion, actually, I don't have the diffusion weighted images, and it has been proved to be an epidermoid cyst.
يعني انا بالنسبه لي لو جات الحاله هقول ان هي intramedullary lesion for differential diagnosis.
Yes, and you mentioned the possible differential diagnoses from the list I have mentioned.
طيب.
And what do you think of this?
Tethered cord?
No, the cord is
the same برضو.
lymphoma.
Yes, what's evident here is the diffuse low signal of the bone marrow and the T1 weighted images. And this diffuse low signal is assessed by comparison of the vertebral body to the intervertebral disc. Normally, the bone marrow is fatty and is very bright compared to the intervertebral disc. But if you see that the intervertebral disc is more brighter than the bone marrow, then you should look for a pathology in the bone marrow. But before looking for the pathology, look in the T2. Is this lesion persistent black in the T2 as well, or will appear some bright in the T2? This will help you in the differential diagnosis, because myeloma will have diffuse bone marrow infiltration, and that will appear in the T2 weighted images of bright signal. And this is different from another disease which is known as myelofibrosis. In myelofibrosis, there is a fibrosis of the bone marrow. Then you got low signal in the T1 and also low signal in the T2 weighted image. And you know that myeloma is the most common primary malignancy of the bone. It represents 1% of all malignant diseases, 10% of hematologic malignancies, and is diagnosed by many laboratory tests. But in MRI, you may got multiple lesions of low signal in the T1 and high signal in the T2, or you may got diffuse bone marrow infiltration. And in this case, you see that the bone marrow is low of low signal in the T1 and also of low signal in the T2, and this is myelofibrosis. Myelofibrosis means that there is replacement of the bone marrow by fibrous tissue, and this will result in persistent low signal of the bone marrow in both T1 and T2 weighted images. Yes.
It's lipoma. Intramural lesions.
Intradural lesion. Yes?
Intradural.
Intradural
Lipoma.
Lipoma.
Meningioma.
Meningioma.
And this is a phylum, Bendymoma. Did you see a low signal in the T1, increased signal in the T2, homogeneous post-contrast enhancement? Diagnostic possibilities have been repeated many times, and they include number one, meningioma, neurofibroma, schwannoma. If there is a non-primary malignancy, consider metastasis. Then the next is the phylum terminal or the phylum ependymoma. And what do you think of this?
Spondylolisthesis.
Yes, multi-level spondylolisthesis. Do you think it is lytic or degenerative?
Degenerative.
No. There are, of course, it's
no, lytic grade 2.
And you see, there is the break of the bars, but without the axial image, you can see that this is grade 2.
Grade 2.
This is grade 2 also. And in grade 2, you consider fracture of the bars. Because the grade 1 spondylolisthesis is that where you look if the bars is intact or broken. But after grade 1, the bars should be broken in order to the vertebra to move on the lower vertebra.
Subdural lesion? The epidural abscess, I think.
Yes.
Marginal enhancing lesion.
Okay. This is a good possibility. And you look for number one, the bright signal in the disc. And this is very important. Yes, indicating that the disc is inflamed. Then you have a collection inside the spinal canal, which is marginally enhancing. Then this is diagnostic of yes, discitis with epidural abscess. Yes.
Migration. Disc herniation with cephalic migration.
And sequestration. This is important. You remember the double fragment sign. And this is a newly described sign to assess the disc sequestrated
double fragment sign, sequestrated. Okay.
And what do you think of this?
Intramedullary lesion. Intramedullary lesion.
Okay. Intramedullary lesion of low signal in the T1, high signal in the T2, and enhancement, post-contrast. Intramedullary.
Astrocytoma.
Okay, wait. In the, for ependymoma, you should have a solid component. For astrocytoma, you should also have a solid component. And you remember in the lecture that ependymoma is characterized by hemorrhage, and this is one of the important diagnostic signs. But if you see a longitudinal abnormal signal within the spinal cord, then the diagnosis is transverse myelitis. And transverse myelitis can sometimes enhance. Then transverse myelitis is not a diagnosis. It is just a description for differential diagnosis. What are the causes of transverse myelitis or the causes of abnormal signal inside the spinal cord? Infection, autoimmune disease, and MS. Yes, a lot of lesions, and this is just an example of an MS lesion. It is not seen in the T1 and is seen in the T2, and whenever it enhances, then you consider the possibility of activity, because enhancement in the of the MS lesions indicate activity. Then what do you think of this?
Excuse me, doctor. Excuse me, the previous lesion. If we want to comment, we will say intramedullary lesion or abnormal bright signal intituated image.
This is an intramedullary because it is inside the substance of the cord.
Okay. And intramedullary lesion for differential diagnosis, not this, the previous one, the question.
Yes, MS is an intramedullary lesion, actually.
No, doctor, about transverse myelitis,
Yes.
the diagnosis of transverse myelitis.
Yes, you should say
For comment,
this is an intramedullary abnormal signal extending from so and so, and it shows loop signal in the T1 and the bright signal in the T2 weighted image.
And for differential diagnosis.
Yes.
Okay, thank you.
Then, what do you think of this?
This is
Exopapillary ependymoma.
مش انت the intradural lesion ده.
Yes, and you see a lesion of intermediate signal in the T1 and in the T2 with significant post-contrast enhancement. Then what do you think of this lesion? Is it a meningioma?
Maybe his meningioma.
Is it a
Exopapillary ependymoma.
Yes, it may represent a neurofibroma or a phylum ependymoma, and this case has proven to be an intradural lymphoma. Intradural lymphoma is rare and is not included in the differential diagnosis, but you may remember that it is not common. I mean that you should not mention lymphoma whenever you see an intradural lesion, but you should say meningioma, neurofibroma, schwannoma, metastasis, phylum ependymoma. Then you mention the non-neoplastic lesions. And here are the neoplastic lesions which do not include lymphoma: meningioma, neurofibroma, schwannoma, metastasis, and ependymoma. Of course, paraganglioma is written in the literature, but is not frequently seen in the clinical practice. Then, what do you think of this?
دكتور ترانزفيرس myelitis وفي disease اللي هو الليتوماجير carcinomatosis.
Okay, then actually look for the history. There is a car accident followed by quadripartite. Then
transverse myelitis. Transverse myelitis.
Okay, wait. This is T2 and this is post contrast. In the T2,
it's called the swelling.
Yes, you got diffuse swelling of the cord, okay? And this may be due to edema or maybe due to infarction, for example, post-traumatic, okay? Then if you inject the contrast material and see some enhancing vessels along the surface of the cord, then this means that there is a fistula between the vein and the artery, which is known as the dural arteriovenous fistula. This is the follow-up of the patient after closure of the fistula. Then what happens when you got after trauma or after surgery or even spontaneous development of a fistula tract between the one of the spinal arteries and the vein. Then what will happen for the cord? The cord will be ischemic. Why? Because of the shunting of the blood from the arterial to the venous side directly without passing to the capillaries. And this is one of the very important causes that for the patient to develop acute quadriplegia or paraplegia with disturbance of the urine and fecal habits. And this dural arteriovenous fistula is commonly missed in the clinical practice because if you look here and you can see some vessels, you say these may be the normal epidural vessels or the artifacts or whatsoever. But if you look carefully in the T1 and you see this vessel, which is abnormal, and in the T2 weighted image, which is an important factor, you can see that the cord is not normal. The cord is edematous or ischemic. The actual word, the cord is ischemic. And in the gradient image, which is better for detection of the vessels, you can see clear enough the vessel. And after injection of contrast, you can see the enhancement. And this is another example, which is easily overlooked in the clinical practice. You see many vessels in the subdural space, and you look for the cord, and you can see abnormal signal. And I have seen a case in the clinical practice with a young adult presenting by acute paraplegia and loss of urine and fecal control. Then most of the clinicians could not appreciate this abnormal finding. Then, whenever I look to the MRI, he had a lot of MRIs before and after contrast with diffusion, and it's all what you can imagine. And if you see these vessels in the subdural space, and you see changes in the cord, you should know that this is dural arteriovenous fistula. I think this is the last case, and we have about two more minutes before the closure of the Zoom.
Lymphoma or epidural abscess?
Yes, and you have an epidural lymphoma. This is a good possibility because of the enhancement and the extraosseous soft tissue component, which is also seen in the axial images. And this is the differential diagnosis of epidural lesions, which include hematoma, abscess, deposit, arachnoid, dermoid, epidermoid, and the lymphoma. Thank you very much. وأنا أراكم على خير إن شاء الله.